Hello, everyone, and welcome back. My name is Dr. Ben Osevwe, and today we are talking about bulimia nervosa. This lesson is for PMHNP students and providers who want to understand the binge-purge cycle and how to help patients safely. Short disclaimer: this video is for education only. Bulimia can cause electrolyte imbalance, heart rhythm problems, fainting, esophageal injury, dental damage, and suicidal thoughts. If someone has chest pain, fainting, vomiting blood, severe weakness, or feels unsafe, seek urgent care. Part 1. What is bulimia? Bulimia nervosa is an eating disorder where a person has repeated binge eating episodes, followed by behaviors to prevent weight gain, such as vomiting, laxatives, fasting, or excessive exercise. These behaviors are compensatory and often driven by an intense fear of weight gain or body dissatisfaction. NIMH describes bulimia as regular binge eating followed by unhealthy behaviors to prevent weight gain. A simple explanation is bulimia is like being stuck on a food roller coaster. Loss of control, panic, then trying to undo it. Part 2. What it can look like. Signs may include eating large amounts in secret, feeling out of control during eating, self-induced vomiting, laxative or diuretic misuse, excessive exercise, swollen cheeks or jaw, dental erosion, sore throat, acid reflux, calluses on knuckles, shame after eating, mood swings. During a physical exam, providers should specifically look for bilateral parotid gland enlargement and calluses on the dorsal surface of the hand. Beyond the physical, patients often experience extreme guilt, social withdrawal, and obsession with body shape. Normal weight despite serious illness. For providers, do not assume bulimia based on weight. Many patients with bulimia are normal weight or higher weight. Part 3. Root causes. Neurologically, bulimia may involve reward circuits, impulse control, serotonin regulation, hunger/fullness signaling, and stress systems. Serotonin dysregulation is a key component here. The HPA axis and reward pathways in the brain often become hyper-responsive to food triggers. Psychologically, it may involve shame, body dissatisfaction, perfectionism, trauma, anxiety, depression, impulsivity, and emotional eating. These internal drivers fuel the cycle. PMHNPs must screen for comorbidities. Up to 80% of patients with bulimia have a co-occurring mood or anxiety disorder. Socially, diet culture, weight stigma, bullying, family criticism, sports pressure, and social media comparison can fuel symptoms. Societal pressure to achieve unrealistic body standards creates a breeding ground for disordered eating. Short analogy: bulimia is like trying to erase a text after it was already sent. The person panics and tries to undo eating, but the cycle keeps coming back. Part 4. Treatment options. Treatment may include CBT-E, nutritional counseling, regular meal planning, DBT skills for emotion regulation, family-based treatment for adolescents, medication when appropriate. CBTE is the gold standard, focusing on the cognitive processes that maintain the eating disorder. Medical monitoring, dental care, higher care when purging is severe or unsafe. Medication can treat symptoms of bulimia and co-occurring anxiety or depression. Fluoxetine is commonly used clinically for bulimia. While medication helps manage symptoms, it's most effective when paired with comprehensive therapy. NIMH notes, medication can help symptoms of some eating disorders, including bulimia. Part 5. Nutrition and vitamins. Nutrition goals include regular meals, reducing restriction, hydration, and electrolyte monitoring. Important labs and nutrients may include potassium, magnesium, phosphorus, sodium, B vitamins, vitamin D, iron if deficient, protein, calcium, dental protection, education. Potassium is vital for cell function. Severe depletion can lead to cardiac arrest. Purging can cause dangerous potassium loss, which can affect the heart. Board exam Pearl. When restarting nutrition, monitor for refeeding syndrome. Hypophosphatemia is the hallmark sign. Board exam Pearl. Watch for Mallory-Weiss tears or esophageal rupture in severe purging cases. Look for Russell's sign on the knuckles, a classic indicator of self-induced vomiting. Practice. Question: which SSRI is the only one FDA approved specifically for bulimia nervosa? The answer is fluoxetine. It's often prescribed at higher doses than for depression. Practice question. For a patient with severe purging and hypokalemia, what is the most life-threatening immediate concern? The correct answer is cardiac arrhythmias. Electrolyte imbalances directly affect the heart's electrical system. Practice question. Which specific dental finding is most commonly associated with the purging behavior in bulimia? The answer is enamel erosion, particularly on the lingual surfaces, caused by repeated exposure to stomach acid. According to DSM-5-TR, episodes must occur at least once a week for 3 months. Compensatory behaviors are required for the diagnosis, distinguishing it from binge eating disorder. Diagnostic distinction. BMI is the key. Bulimia patients typically have a normal or high BMI. She reports binging and purging 3 times a week. Labs reveal hypokalemia. What is the priority? Let's look at a case study. A 22-year-old student presenting with dental erosion and fatigue. She reports binging and purging 3 times a week. Labs reveal hypokalemia. What is the priority? Priority 1 is medical stabilization and electrolyte replacement to prevent cardiac events. With a team-based approach, she entered a CBTE program and started fluoxetine for recovery. Case study 2. A 19-year-old male athlete who fasts and uses laxatives to make weight for competitions. He doesn't vomit, but his fasting and excessive exercise meet the criteria for compensatory behaviors in bulimia. Treatment involves sports nutrition counseling to break the cycle while maintaining his passion for the sport safely. Provide a pearl. Patients often feel intense shame. Use non-judgmental, compassionate interviewing. Remission is more likely when families are involved, especially in adolescent patients. Relapse prevention involves identifying triggers and developing robust DBT distress tolerance skills. Normalize that recovery isn't linear. Slip-ups are opportunities to learn, not failures. Long-term care requires ongoing monitoring of medical, dental, and nutritional health. The PMHNP often coordinates this multidisciplinary team for the best patient outcomes. Today, we learned that bulimia is not simply overeating or vanity. It is a serious binge-purge cycle involving shame, fear, body image, impulse control, and medical risk. We've covered the definition, root causes, treatments, and key pearls for your board exams. The main message is bulimia is treatable. Recovery includes therapy, nutrition support, medical monitoring, and compassion without shame. Again, my name is Dr. Ben Osevwe. For support, text 832-991-6516. Subscribe to our YouTube channel and join our mentorship family at rotationmatchnetwork.com.